Okay, we are now live.
Hello, everyone, and welcome to Rare Share Rare Genomics Institute session of our podcast series, Ask the Expert. This podcast will focus on advances in adrenomyeloneuropathy (AMN) from a clinical and research perspective. My name is Deepa Kushwaha, and I am the scientific director for Rare Share Rare Genomics Institute. Hosting today will be Imogen Crisp, Rare Genomics podcast organizer. Imogen, can you tell the listeners about Rare Share Rare Genomics Institute?
Hi, everyone. Yes, thank you so much for being here and taking part in this podcast. So, the mission of Rare Genomics Institute is to help rare disease patients find hope for a cure by helping patients secure funding and obtain a genetic sequence of their disease. The rareshare.org social networking platform provides an online community and support system for rare disease patients, families, and healthcare professionals who may otherwise not know anyone else suffering from their disease. So Rare Genomics helps patients in a number of ways. They help with overcoming financial barriers for rare disease patients, such as the uninsured and underinsured patients. They help with overcoming communication barriers, such as lack of understanding, language, and cultural barriers. They help with overcoming medical system barriers, fragmented medical systems, missed appointments, or lost results. Also with overcoming psychological barriers, such as fear and distrust. And finally, overcoming other barriers such as transportation and need for childcare.
Also, a quick disclaimer before we start. We are sharing a lot of state of the art and new information. This is just for educational purposes and not a medical advice. This is not to replace talking to your doctor. So, if you have any specific questions, make sure you do talk to your doctor. We hope this will be a helpful resource just for educational purposes. Since the podcast is an opportunity for the general community to engage with the experts, we have provided a mechanism for listeners to ask questions. As many of you have already submitted questions prior to the podcast, we will try to provide you answers to the featured questions and also post all the podcast link and responses in the Rare Share Adrenomyeloneuropathy community forum and also at the Rare Genomics website.
Great. So without further ado, let's begin today's Ask the Experts podcast. So Deepa, can you introduce our experts?
Happy to, Imogen. As mentioned, today's segment will focus on helping patients living with AMN from a clinical and research perspective. Our first expert is Dr. Paul Orchard. Dr. Orchard is a professor of pediatrics in the Division of Blood Marrow Transplantation at the University of Minnesota, Minneapolis. He is also the medical director of the Inherited Metabolic and Storage Disease Bone Marrow Transplantation Program. Dr. Orchard attended medical school at Brown University, served his residency at the University of Wisconsin-Madison in pediatrics, and he has also held a fellowship at the University of Minnesota. Dr. Orchard's main interest focus around the use of blood and marrow transplantation and potentially other cell therapies for inherited metabolic diseases like Hurler syndrome and adrenoleukodystrophy. He has developed new therapies specifically for this group of patients with the goal of minimizing neurologic deterioration during the transplant process, including the use of antioxidants, reduced intensity transplant regimes, and combination of therapies such as transplant and enzyme replacement. This work also benefits other children undergoing transplant, particularly in regards to our commitment to minimize the side effects of transplantation. In addition to his clinical work, Dr. Orchard also focuses on basic research studies in regards to determining strategies to enhance the delivery of enzymes to the brain and the peripheral nervous system for patients who lack specific enzymes. In addition, he has been interested in testing other types of stem cells that may improve outcomes for patients with inherited diseases, including gene therapy approaches. He also leads research and clinical care for patients with osteoporosis, an inherited disorder leading to increased density of bone, for which BMT is a treatment option. Dr. Orchard is considered an international expert in this disorder and its treatment. Welcome, Dr. Orchard. Dr. Our next panelist is Dr. William Rizzo. Dr. Rizzo is a professor of the Division of Inherited Metabolic Diseases at the University of Nebraska Medical Center. Dr. Rizzo attended medical school at the University of Illinois, Chicago, and he completed his residency at Johns Hopkins Hospital in Baltimore, Maryland, and he was the fellow at the National Institute of Health. He has been in practice for more than 20 years. Dr. Rizzo's research is directed towards understanding the genetic and biochemical basis of inherited metabolic diseases, with a particular emphasis on the disorders of lipid metabolism and diseases which cause a variety of symptoms involving the brain, nerves, skin, and eyes. The investigation in his lab ranges from basic research on biochemical pathways to discovering unrecognized genetic diseases that affect metabolism in children and adults. Dr. Rizzo is particularly interested in Sjogren-Larsen syndrome, and his research has identified the cause of several genetic diseases and led to the development of new diagnostic test and treatment approaches. Welcome, Dr. Rizzo.
Hello. Please don't hang up.
Yeah, thank you very much for those introductions, Deepa. So welcome, Dr. Orchard and Dr. Rizzo. It's really great to have you both here. So glad you could join us. So we will now transition to our Q&A section. So Dr. Rizzo and Dr. Orchard, maybe one of you could start by telling us sort of how many different kinds of AMN patients there are and what are some risk factors for AMN?
Well, Bill, so I'm going to let you deal with some of the issues that are more prevalent in the...
Oh, I think we just lost Dr. Orchard, unfortunately. Dr. Rizzo, are you able to take over from here?
Sure, absolutely, yes. So let's give it a little background here, because AMN is one of the phenotypes of X-linked adrenoleukodystrophy. And as you probably know, there are different phenotypes of that underlying disease, AMN being probably the most common of the types that we see. So AMN patients can be divided up into those who have something called pure AMN, which involves spastic paraparesis and adrenal failure. And then there are AMN patients who develop cerebral demyelination as well, eventually in the course of the disease. In addition, I think we can classify some heterozygote female carriers for the gene as developing symptoms very similar to AMN and could be classified from a clinical point of view as AMN itself. So really there are three groups of patients within this AMN category: the pure AMN, AMN who develop cerebral disease ultimately, and then the female carriers. Now, the risk factors for developing one type of this disease versus another are really not well understood at all. We know what the basic underlying genetic defect is. We know what the biochemical defect is, but we don't know what determines someone developing AMN, either pure AMN or AMN with cerebral involvement, or the childhood form of X-linked ALD, which is a severe progressive disease that we see in boys. So there's a lot yet to be learned about this disease.
Right, yeah, that makes sense. I think Dr. Orchard has managed to rejoin the call. So I was wondering, Dr. Orchard, if you had anything else you'd like to add to that question with your knowledge of ALD. I think his microphone appears to be muted right now. All right, well, let's continue anyway. So the next question we have is, what are the kind of first array of symptoms that someone would get if they were likely to have AMN, and what is the prognosis?
So it turns out that the symptoms of AMN vary somewhat from patient to patient. The first symptoms, I think, can be divided up into those that involve the nervous system versus those that involve the adrenal glands. So some patients with AMN will develop adrenal insufficiency, otherwise known as Addison's disease, before they develop any neurologic symptoms whatsoever. And that onset of adrenal insufficiency can occur in childhood or later in adulthood. However, the initial neurologic symptoms of AMN are oftentimes initially noted as stiffness in the legs, perhaps upon awakening in the morning, and then that might clear up throughout the day a little bit, but over time, as the disease takes hold more, I think the stiffness tends to progress to the form of a more frank spastic paraparesis, where they have more difficulty walking and running. So what you oftentimes find is that these symptoms develop sometimes perhaps even in the late teenage years, or in the 20s or 30s, or even later than that for that matter. And they progress over a period of time, usually rather slowly. So with this kind of a presentation, as you can understand, if you have an onset of disease earlier in life than later, then of course the disease has a longer period of time to progress. Some patients will develop symptoms of AMN in their 40s or 50s, sometimes even later than that. But the adrenal insufficiency may be present or may not be present in any individual patient. So it's important to note that we have patients with AMN who have no adrenal insufficiency, and in their 50s and 60s when the first symptoms develop. And we have other patients who have developed adrenal insufficiency in late childhood, early adulthood, and along with the symptoms of the spastic paraparesis. So there's a lot of variation in this disease, and the time course over which it progresses varies as well, but is usually rather slow. So unlike the childhood X-linked ALD form that involves the brain initially, these patients with AMN typically have a longer time of progression, and it really varies a lot from patient to patient. So it's impossible to really predict ahead of time how severe the disease will progress and how rapidly it'll go on.
Thanks, Dr. Rizzo. That's really informative, very interesting. And I think Dr. Orchard is back now. Are you there now, Dr. Orchard?
Yeah, I think so.
You are.
Thanks. I think it's important to realize, as Bill was pointing out, that all these various subtypes that are manifest of ALD can occur at various times in patients' life, and the cerebral form of the disease, for instance, which is generally characteristic of the younger patients, the kids that are school-age patients, can happen as patients are older too. So it's really difficult to predict, and certainly genetics, for instance, doesn't tell us what different people are going to experience as they get older. And even within a family, so you have the same mutation, it may not predict at all who's going to have what types of problems. So there's a lot that we don't yet understand, and almost certainly there's other genes and pieces to the puzzle here that we need to get a better sense of to help people anticipate what kind of problems they may have.
Right. Okay. Yeah, that makes sense. Okay, so we've got a question from a community member now. This is a woman from Dubai, and she says, "My husband has AMN. I have 2 sons. Will my sons inherit the disease, and will my sons' children inherit the disease? And if I have a daughter, is it possible for her to inherit the disease?"
So I can address that question. It turns out that AMN, as other forms of X-linked ALD, is inherited as what we call an X-linked trait. That is, the gene is located on the X chromosome. So a female typically might be a carrier for the gene because they have one X chromosome that carries the gene on it, and the other X chromosome does not carry the gene. On the other hand, a male has one X chromosome and one Y chromosome. So if a male has the disease, they have their X chromosome with the gene on it. And when they have children, they pass along that X chromosome to all of their female daughters, okay? And Males, on the other hand, inherit the Y chromosome from the father, and so they do not inherit the X chromosome. So if a man has AMN, they can pass along the gene, and they will pass along the gene to all of their female children, but they will not pass the gene along to their sons. So the sons are essentially free of carrying that disease, and at that point, the genetic aspects are such that they do not pass any gene on to their children in the future.
Okay, right. That's great to know. And another question from a community member, it is Joyce from Indiana. She says, my 2 brothers and my son all have AMN/ALD, and they have all had heart attacks. Is there some relationship between AMN, ALD, and heart disease?
Well, to my knowledge, there is no connection between heart disease and AMN. I don't believe we have heard of any correlation between the two at this time. That's simply to say that we haven't studied that, and so it may be that in the future someone will see that, but at this point I would say there is no correlation between the two.
Yeah, there's no association that I've heard of either, and it's difficult in a situation like that where there's a history of heart disease in the family to know if that's an independent issue that runs in the family or whether that's related somehow to the ALD, but I'm not aware either of any association of cardiac disease and ALD or AMN.
Okay, thank you very much for those answers. Okay, and we're going to talk a bit more in detail about symptoms now. We have a question from a community member, Nan, who is from Ontario, Canada, and this person says, why does AMN have so many diverse symptoms, and how do they all tie together?
Well, that's a very good question, and it's a question we don't have a good answer for. The symptoms of AMN we know about in general are the spastic paraparesis, that is the difficulty walking, and urinary problems. But we don't really know and understand the mechanisms for all of this. It's quite perplexing to us that if you inherit the gene, even within the same family, you can have some people who have AMN and other people who have X-linked ALD, the childhood cerebral form. And we don't understand why people in the same family that have the same gene have other forms of the disease. So when we start looking at AMN itself as a more pure disease, we have to realize that there's a lot of things that we don't understand as far as the symptoms are concerned in any patient. At this point, there's a lot of speculation as to why you have AMN versus a childhood cerebral form of the disease. People have been talking about modifying genes or modifier genes for some time, but at this point we don't have a solid idea as to whether or not there are such genes, and also what those genes are. However, it seems reasonable to speculate that there are other genes that one inherits from your parent or parents that could influence the expression of AMN, and that probably is the case. The other aspect of the disease we don't understand is whether environmental factors have a play in this. There is certainly evidence in childhood cerebral disease that a damage or a stress to the brain can induce earlier onset, perhaps, of cerebral demyelination, but we really don't understand the impact of environment on this disease. And when I talk about environment, I also include diet, for example. So there's a lot yet to be learned that we don't understand.
Right, yeah, well, we've got a few more questions later on about sort of diet and lifestyle, so we'll come back to that. We have another question from a community member, another member from Canada, and she asks, is it common to feel toes feeling compressed as though they are being crushed together?
I think that this probably is a factor of the neuropathy that's part of of this disease and the spasticity in the lower extremities particularly. I don't know that it's common to feel like your toes are crushed together, but I think that that probably is a feature of that involvement.
Okay, that makes sense. And just another question from our host list of questions here. If left untreated, can AMN lead to the development of other diseases? And if so, what are they?
Well, I don't know if there's other diseases that I would necessarily correlate. I mean, there's certainly problems that people have as they they progress with their AMN that may be related somewhat to their disease in terms of urinary tract infections and constipation and all these other types of things. So whether or not there's true distinct diseases that are associated with it, I don't know, but the manifestations of the disease as they progress certainly can lead to a number of different types of issues for people.
Yeah, I would agree, Paul. I think that you can get secondary changes due to the spastic paraparesis and involvement of the peripheral nervous system in AMN. But I don't know that there are other unrelated diseases that develop because of the AMN. You might comment about the onset of cerebral symptoms in AMN, since that's very important to this group of people.
Yeah, so in terms of cerebral disease, so the onset of demyelination within the brain, which is what we call the cerebral form of the disease, is there's a lot that's unknown about how that occurs too. So there's some trigger that results in basically an inflammatory process in the brain. So we think it's related to the accumulation of very long chain fatty acids, but exactly how that works and why some people get it and some people don't is something that we really don't understand. But about 35% of boys out to age 15 get the cerebral form of the disease. And again, even within a family, some boys may get it and some boys don't. But the peak incidence of starting to have symptoms with cerebral disease is about age 7. It's pretty uncommon that we'd see it before the age of 4, but then there's a long kind of tail off in terms of when people can get cerebral disease. And so certainly people even in their 20s and 30s that are experiencing problems with AMN can still develop cerebral forms of the disease. So if there's a slowly progressive issue that seems very well associated with what we'd expect from AMN, and other things start to happen that seem different, for instance, having an MRI done to look for the cerebral form of the disease would certainly make sense. So we see a lot of people that have cerebral disease, and so my trigger for getting an MRI may be a little less than many, but it's a very important piece to tease apart, is that it's not necessarily that as you have problems as you get in your 20s and 30s, or even a little later, that's can only be the AMN form of the disease, because the cerebral form may pop up as well. Okay,
yeah, that's really interesting. Okay, and we're going to move on to, since we're already sort of starting to talk about diagnosis, I was wondering if there are any disease-specific genes, pathways, or metabolites targeting AMN, and how can that help with diagnosis?
Well, the diagnosis of AMN is pretty straightforward. We now have available blood tests that will measure accumulation of very long-chain fatty acids in the blood of patients. And this is an important test that is now widely available compared to a couple of years, or I should say a couple of decades ago. The test itself is pretty specific for ALD or AMN with 1 or 2 exceptions, and is quite reliable. The alternative approach to diagnosing this disease is to use genetic studies, but I find that the vast majority of patients are diagnosed with a simpler and more rapidly performed blood test of fatty acid levels. So the diagnosis is there, and that is easy enough to understand. What happens after that with respect to the genetic defect is where we are really not knowledgeable as much as we would like to be. So we know this leads to accumulation of very long-chain fatty acids in the body of patients, and there is some evidence that those fatty acids can induce cerebral changes, for example, in certain cells within the brain that activate them, and they become very active and start synthesizing molecules which stimulate inflammation in the brain. But why that happens only in the childhood form of the disease with cerebral involvement, or in the adult form with cerebral involvement, and not with the pure AMN disease, that is without cerebral involvement, is really still a mystery to us. So we understand how to diagnose patients, but we just don't understand the mechanisms leading to the symptoms. And therefore, what's going on now is research into understanding that mechanistic link between the fatty acid accumulation and the symptoms of the disease. So that's an area of hot research right now, and very active involvement. We're going to see more about this in the future.
I would just mention too that in terms of making the diagnosis, that the sophistication of that is now to the point where you can diagnose that on a blood spot when a baby is born. And so there's this process of assessing what diseases might be screened for in terms of newborn screening. And the federal groups that review these kinds of things have made a recommendation that ALD be considered in terms of newborn screening. So essentially, when a baby is born and they have a kind of a heel stick done, and they put a few dried blood spots on a card, and that can go off for testing, that now some of the states, including some of the larger states like New York and California, are doing screening for ALD. So in those states, including here in Minnesota, there are babies now being picked up that are essentially newborns that are identified as having ALD. And I think it'll give us an opportunity to follow these patients more closely and potentially anticipate problems that they may end up having from birth. So that's an important new development. And in terms of identifying, again, who's going to have AMN and who's got cerebral disease and whatnot, it's not going to help us with that piece, but it'll allow us to determine from very early in the course of somebody's life that they have ALD.
Right, yeah, that's really good to hear that there are some great methods for diagnosis. Very good. And I was wondering, are there any actual designated specialists for these kind of diseases that patients can go and see in their state?
So that's a good question, and it's also one that we wish we had a better answer for at this point. So typically, patients at all ages with ALD would be referred to a pediatric neurologist who would be able to manage the neurologic symptoms of the disease. In some cases, because the patients initially present with adrenal insufficiency, they may be referred to endocrinologists to make a diagnosis and to manage that aspect of the disease. And then I would say, finally, the geneticists are oftentimes people will be referred to because they have a kind of a broad knowledge of the genetics and can provide all kinds of genetic counseling, and also are oftentimes useful in making a diagnosis. So the specialists don't hang out a little shingle that say, I am an AMN specialist. That doesn't happen. But you have to really look and seek help, oftentimes by seeing people, specialists who are present at academic medical centers, for example, or even contacting some of the family organizations that are active in ALD involvement. And so the United Leukodystrophy Foundation is one, ALD Connect is another one, and so those people that run that organization have contacts with physicians around the country or even outside of the United States, and therefore can oftentimes provide a name to which you can go to for seeking help.
I think it's important to understand too, so there's a number of different providers in terms of physicians, for instance, who might see patients, but a lot of individuals, I think, get benefit from ongoing relationships with physical therapy people or occupational therapy types or other people that can help maximize function and keep people as active as they can potentially be. So I think the supportive care groups from that standpoint can be really key as well.
Yeah, that's really helpful information. And so we're going to move on to some questions about treatment now. I was wondering, well, actually, let's start with a patient, a community member question. We've got Justin from Arizona who's asking, what can be expected in the coming years regarding therapies for AMN?
I'd like to refer the initial response to Paul, who can discuss bone marrow transplant, gene therapies, and so on. And then I can chime in on some of the other approaches that are being looked at right now as far as medications.
So in terms of the blood and marrow transplant piece, so it's back really in the 90s when it became evident that blood and marrow transplant can help with cerebral disease. And since that time, transplant's been used extensively, almost exclusively for the patients that have this neuroinflammation problem, the cerebral problem. So it's primarily been in the boys. Whether or not transplantation affects whether you're going to get AMN or not is a really important question. And it's been difficult to get at because most of the boys that have been transplanted were really transplanted in the 5, 7, 10-year age group. And there's not many of them because, again, we started doing this in the 90s. Not many of them are in the 30-year-old categories to really be able to see if they're developing AMN or not. So that's a fundamentally important question. There's been some descriptions of people that have been transplanted that have developed AMN, so I don't think having gone through a prior transplant is going to fundamentally change whether you can get AMN or not, but it's certainly possible that it may modulate how it progresses or the rate or the severity or whatever. So that's something that we're trying to look at actively by pulling together the patients, the oldest patients that have been transplanted essentially throughout the world and trying to look at how they're doing and compare them to patients that are in the same age groups that haven't been transplanted. So that's an ongoing investigation that we're really trying to get off the ground because I think that's going to end up potentially being very important. So again, right now we're just doing transplant for patients that have cerebral disease and not for AMN because we don't know that transplant will change the course of the disease in terms of AMN. But if we determine that that was true, then that might open the door to doing more transplants earlier. Another piece that's really kind of fundamentally important is the development of gene therapy. So, it's the ABCD1 gene that is defective in men that have AMN and boys that have cerebral ALD. And so when we do bone marrow transplants, we use somebody else's blood stem cells to do that. And there's a lot of complications in doing that, and because you're essentially switching one person's immune systems for another, Transplant is difficult and expensive, and you're in the hospital a long time, and there's a lot of complications, and sometimes people die going through transplant. So it's not something we want to do unless we really feel like we need to do it. But what's being developed, or at least tested now, is putting back in the ABCD1 gene into patients' own cells. So essentially what happens is you harvest their own blood stem cells. There's a virus that carries that gene that we use to put into it. And the company that's doing this is called Bluebird Bio. But they are developing this technology so people can get their own corrected cells back and not rely on somebody else's blood stem cells. And that's a much easier procedure to do. And people tend to get less sick. They're in the hospital for a lot less extended periods. It's going to be cheaper, and it's going to be easier if it ends up being as effective as using someone else's cells. So again, that's being studied, and we'll see in the next few years. We'll probably have an answer as to how well that seems to work. But that would be much easier to do in the future than doing what we call allogeneic cells, or transplant, meaning using someone else's cells. So we'll see, but those are really important pieces that are in development. And again, the impact that they may have for AMN is difficult to know yet, but they certainly may have some applications to people that have AMN as well.
Right.
Now, I think I'd like to say a few words about therapeutic approaches that are being explored or potentially explored in AMN patients. One nice thing about the current atmosphere is that there is research going on. It's at a number of centers on X-linked ALD. And although the focus has been on the boys with the active demyelinating cerebral involvement because of the urgency of the disease there, I think more is being understood about the mechanisms of what's going on at the cellular level and the biochemical level in patients. And that is giving us clues as to where this therapy will go in the future, or may go in the future. So let me just summarize. There are a few areas that have been explored and that may provide some promising clues. So as you know, there's a lot of interest in multiple sclerosis, and there are drugs being developed, a number of them now, to treat MS symptoms. And some of them may be at some point applied to patients with AMN if the biology indicates it's worth doing that. So for example, there's a drug called 4-aminopyridine, which has been used in MS patients to help them with ambulation. And there's been an uncontrolled study in a group of AMN patients, provided this drug to actually demonstrate that maybe 20 to 30% of them were able to walk faster when treated with the drug. Whether that's a sustained response or not is something not known, because the trial was quite short, maybe a month or so. In addition to that, there's been research going on to indicate that there is what we call oxidative stress going on in cells and tissues of mice with the mouse model of AMN. And for example, increased oxidative stress leads to the accumulation of what we call free radicals, oxygen-free radicals, which are harmful. And these free radicals accumulate in a number of chronic diseases that affect the nervous system. And so there is interest in that with respect to AMN as well. And there is good data in the mouse model for AMN to indicate that if one treats these mice with antioxidants, that the mice seem to do much better with respect to their ability to walk and run. And that has led to some initial clinical trials looking at antioxidants in AMN men. These have demonstrated a biochemical response so far, but have not really demonstrated a clinical improvement in the patients. But nevertheless, there are other approaches looking at these areas of biochemical abnormalities that are secondary to fatty acid accumulation. So there are drugs, for example, that are being investigated. For example, one is an antioxidant called resveratrol, which at the cellular level has some potential benefit for cutting back on the oxidative damage, as well as another drug called pioglitazone, which is used for treatment of diabetes. In addition, there are other approaches being used. Another diabetic drug called metformin has been shown to have some potential benefit in an animal model with AMN, as well as a drug called tauroursodeoxycholic acid, which is a bile acid that's available. But what happens in mice with respect to drug response and improvement does not necessarily translate to what happens in humans. And so what we're faced with here is a number of possibilities that can be explored in people with AMN, but the studies, to my knowledge, are still waiting to be done. Additional studies ongoing relate to treatment of childhood ALD with vitamin D supplements. And there's studies now that are promising, that are done in animals, that indicate that a thyroid hormone antagonist, or agonist, I should say, a drug related to thyroid hormone, may be beneficial for the animal model. So what we're seeing now, in a way that we hadn't seen in the past, is that we have a lot of potential approaches to treating this disease based on our better understanding of what the pathogenic mechanisms are in this disease. So I think we should look forward to the potential for seeing some of these being translated into clinical trials. Whether they'll show benefit, of course, in people is not known until that's done.
Thanks for that. That's very interesting. And we have another question from a community member, Kevin from California, and he says, a lot of pain medication that I try doesn't help as much as it should. Would the demyelination account for this? And could my nerves not be sending the medication effects to the correct receptor?
Well, I don't know if there's a great answer to that question. I think for specific individuals, some drugs may work better than others, but it's I think it's going to be a problem for a lot of people. And it's difficult to be able to make some sort of recommendation without having an idea what medications we're talking about, what kind of doses they might be, and whatnot. But I think from just globally, different people are going to respond to different medicines in different dosages, and so some of this, unfortunately, is kind of a trial and error thing to see what seems to work best for individuals.
That makes sense. Great, thank you for that. And I think we are going to move on to the next section now. The next section we have here is research. I think we have discussed research a little bit, but I was wondering, I have a question here. I was wondering if it might add to what we've already discussed. We're wondering, how can recent research help with dealing with AMN, and do we have enough data and retrospective study information to conclude the findings?
So it turns out that in general we have less information than we would like with respect to research in this disease. I think that the question really is, we're understanding more at the basic cellular level as to what is abnormal in AMN patients, and whether those abnormalities lead to the symptoms, and if so, how they lead to the symptoms. What is oftentimes ignored or, let's say, just delayed is the application of these findings to the actual people with AMN. And that brings us to the question of how we go about doing clinical trials in AMN, and what's the best way to do that. So if we have a drug or a therapy that might be beneficial for patients, we need to enroll patients with AMN into those studies. And AMN is a rare disease, even still. And so it's difficult to get enough patients enrolled in studies to do good clinical trials of new treatments. Oftentimes, the initial approach is to use what's called an uncontrolled open label trial where you treat everyone with the drug and then look what happens to them over time and see if they respond. The problem we have with these kinds of trials is that we don't have a control group to go by, and we only go by historical controls, which is notoriously ineffective as far as being able to evaluate the response of a patient to the drug. So I would encourage anyone who has AMN to reach out, explore, and see how they can participate in these trials, because that, in many cases, that's one of the limiting factors as far as studying new therapies for this disease. So I think that I would say that the application and the transfer of what we're learning from the basic science level to the clinical level is going to be done, but it requires everyone to join in and help in this regard.
That makes sense. And do you have any tips for how patients can find out about clinical trials and make sure they can participate in them?
Yeah, there is a website, www.clinicaltrials.gov, that will list all the clinical trials that are ongoing on any disease, AMN being one of them. And it will also tell you what the trial is about, where it's being carried out, whether they're recruiting subjects for the trial at this point in time, or whether they have completed recruitment and are just waiting to see the results of the study. So I would direct anyone to that site, www.clinicaltrials.gov, which really lists all those clinical studies that are ongoing.
No, I'd agree. I think that's the best source of information for what might be coming down the pike. And some of the trials are actually listed there before they even open. So I think that's a great resource. In terms of the research-related pieces and how they may help with clinical trials and whatnot too, there's a couple issues. So there is an animal model of ALD. There's a mouse model. It's not great. So a lot of times as researchers rely on animals that have the same diseases, but even though the same gene essentially has been knocked out in the mouse, it doesn't act quite like people that have ALD. So it makes it a little harder if you're trying things in the mice, for instance, to get a sense of what might work and what might not work. It's hard to know for sure that what you learn in the mouse is really going to help on a clinical side of things. Another issue, I think, is that for slowly progressive diseases like AMN, some of the potential treatments that are going to be available are going to help prevent progression of the disease. It's tough to test those things because it's hard to know for any particular individual how fast their disease was going to progress. And so if you make it a little bit better and so they're progressing quite so quickly, how do you know that for sure? And so that gets back to the natural history studies that we were talking about too. But it's a tough disease. The very slowly progressive diseases makes it harder for us to study because it requires a long follow-up, for instance, to be able to make sure that you're actually seeing something that's of benefit.
Right. Yeah, that's really interesting. Thank you for that. And we had about 3 or 4 community members from Canada reaching out because they wanted to find out about any clinical trials or research or specialists in Canada. Do you two know of anything happening in Canada?
I don't actually, but Bill, do you?
So I would say that there is no major clinical center doing research on AMN in Canada that I'm aware of. That's not to say, however, that there are not smart, active people who are studying the disease, but I think not as far as a major clinical center for referral. Okay. It's a shame. It's a shame because we should have knowledge about all those. I would say one could check with the United Leukodystrophy Foundation and ask them whether or not they have investigators up there or people that are knowledgeable about AMN.
Yeah, that's good advice. And some of the Canadians who are reaching out were also asking how they could get in touch with other Canadians with AMN, and I would say to them to sign up, join rareshare.org if you can, and see if you can connect up with any other Canadians on there who might have AMN, so you can share your knowledge that way. So that's rareshare.org. We can also put that link in on the video, so you guys can get that.
Imogen, I would like to add one other good resource for these kinds of rare diseases, and that is social media.
Oh yes, good point.
I have been very impressed over the last 4 or 5 years as to the value of social media for getting these patients with rare diseases together. And there are sites devoted to this disease that are present and run by the ULF, as well as other families even, as far as organizations are concerned. ALD Connect, I believe, also has an active website. So I think that I think you can really connect with other people easier on social media than any other way at this point in time.
That's really good. That's a really good idea. Great advice. Thanks for that. Okay, we're on to our last section now. We're going to be talking a little bit about lifestyle. So the first question is from a community member, Aaron, who says, what do you recommend that people with AMN do about physical and mental fatigue? He says he exercises 4 to 5 times a week and tries to get adequate sleep, but finds he is still exhausted most mornings and has trouble focusing throughout the day.
You know, that's really an issue for some patients. I would say, first of all, make absolutely sure that you have proper adrenal hormone replacement,
Right.
And that you're not adrenal insufficient. So if the person does not have prior adrenal hormone replacement, I think they should have that tested, because that can make a world of difference as far as fatigue is concerned. So let's assume that the person is now taking adrenal hormones. I think that checking in with the endocrinologist would be the first way I would go, just to make sure that they're on the proper doses, and that, normally we typically treat patients with hydrocortisone, but there are other drugs that also might be necessary in some patients with AMN, like Florinef, fludrocortisone, and that would provide a way to prevent, let's say, electrolyte abnormalities a little bit better than hydrocortisone would. So that would be the first issue. The second, I think, is important, and that is to get exercise. I think you have to keep mobile with this disease, and you can't just sit. You have to move, and you have to do that to the best extent possible. So physical therapy is important as well, and I think that is something I can't overemphasize with these kinds of chronic diseases that involve the nerves and the nervous system.
That's great advice. And then, are there any other lifestyle changes you recommend, such as diet or anything else that can help improve the quality of life for these patients? So
there's a lot of questions about diet in this disease, and I can go back many years with this with respect to Lorenzo's oil. So it turns out that the benefit of Lorenzo's oil isn't established in patients with AMN at this point in time. Although there have been studies out of Europe that have treated patients with AMN with Lorenzo's oil for a long time, those studies have been open label studies in the sense that everyone's been treated, and because of what Dr. Orchard mentioned with chronic diseases like that are slowly progressive, it's been very difficult to really say definitively that that dietary modification has an impact. So diet itself, is known to have an effect on our activity levels and well-being. So I would say, it's important to have a balanced diet. I would be absolutely sure to have vitamin supplements, a multivitamin at the very least, daily, to make sure that you're not developing any problems there. And otherwise, lifestyle changes beyond that are variable, and I don't know that there's any consensus on what the best lifestyle should be for these patients.
Yeah, I might expand on that just a little bit. So the Lorenzo's oil, for people that may not be familiar with that, was developed years ago as a means of lowering the very long chain fatty acids in the blood with the hope that it may help prevent disease progression, particularly in terms of the cerebral form of the disease. And then there's a diet that is associated with that again is important in helping decrease very long chain fatty acids. But the utility of that in AMN is, at least to my understanding, pretty unclear. And it's a pretty significant diet to embark on. So, unless we learn more about, those kinds of changes that might actually be beneficial, I'm not sure that that's, something that I would advocate, for instance.
I'd like to add one last thing about the diet there. And people recognize that this is a disease where there's accumulation of very long-chain fatty acids. And so people in the past with AMN and childhood ALD have been put on diets that are restricted in these particular fatty acids. And what happens is these kinds of diets are often deficient in certain other nutrients if you restrict fat intake too much. And there is a biochemical basis to actually avoid these kinds of diets where you have a severely fat-restricted component to it, because we get fatty acids in the body from two sources. One is from the diet, of course, but also, even more important in the case of this disease, is from endogenous synthesis by the body. And if you restrict fat too much from the diet, what happens is the body just gears up and makes more fat endogenously. And that is the major source of the very long-chain fatty acids that accumulate in this disease. So one wouldn't want to be on a low-fat diet only with this disease, because I think that would be potentially harmful, in the sense that fatty acids may increase in the body then. In addition, I think it's important not to lose weight very quickly with this disease, as with other diseases related to lipid metabolism, because again, what happens is you're changing the metabolic status of the body, very much so in the sense of altering fat metabolism, and there's no positive side of losing weight very quickly. Let's say 10 pounds within a month or two. That makes no sense, and I think that would be also counterproductive.
All very useful information. Thank you very much. Okay, well, that brings us to the end of our time now for this AMN podcast. So thank you both, Dr. Orchard and Dr. Rizzo, for being part of this. I think this is going to be a wonderful resource for our AMN community. Great to hear about all the research and treatments and everything. So yeah, thank you so much for making time to do this. And we will make this podcast available on iTunes, and we will put links to it on our Red Genomics Twitter and the Rare Share Twitter as well. So yeah, thank you all very, very much.
Thank you.
Thank you.